Well, hello. I'm Dr. Georges Benjamin. I am the Executive Director at the American Public Health Association here in Washington, D.C. I want to welcome you all to the 5th webinar in the COVID-19 Conversation Series brought to you by the National Academy of Medicine and the American Public Health Association. I'd like to thank my co-sponsor, Dr. Victor Zhao, who's the president of the National Academy of Medicine, for his support in this important effort. We are also grateful for the input of our expert advisory committee, co-chaired by Dr. Carlos Del Rio, Dr. Nicole Laurie. And you can find all of our advisors listed on our website at covid19conversations.org. Now, the purpose of this series is to explore the state of the science on COVID-19 to inform policymakers, public health practitioners, healthcare professionals, scientists, business leaders, and the broader public. More information on the series and recordings of past webinars are available at covid19conversations.org. Now, today's webinar has been approved for 1.5 hours of continuing education credits for CHESS, continuing medical education, and CPH, which is the public health credential. Now, none of the speakers has any relevant financial relationship to disclose. And please note that if you want continuing education credits, you should have registered with your first and last name. Now, everyone who wants credit must have their own registration. All the participants today will receive an email within a few days from cpd@confex.com. That's cpd@confex.com with information on how to claim those credits. I'd like to point out that if you have any questions or topics you'd like to address today on future webinars, please enter them into the Q&A box or email us at apha@apha.org. That's apha@apha.org. If you experience technical difficulties during the webinar, please enter your questions in the Q&A box as well. Please pay attention to the chat for announcements on how to troubleshoot. This webinar will be recorded, and recording, transcript, and slides will be available on covid19conversations.org. Now, I'd like to introduce you to our moderator for today's webinar. It's really my honor to introduce Dr. David Relman. Dr. Relman is a professor of medicine, microbiology, and immunology, and a senior fellow at the Freeman Spogee Institute for International Studies at the Stanford University. He is also chief of infectious diseases at the Veterans Affairs Palo Alto Healthcare System in Palo Alto, California. He advised the U.S. government on emerging infectious diseases, human microbe interactions, and future biological threats, and is past president of the Infectious Disease Society of America. He is a member of the Emerging Infectious Diseases Standing Committee and the Intelligence Committee Studies Board of the National Academies of Sciences, Engineering, and Medicine. He's also a fellow of the American Academy of Microbiology and a member of the National Academy of Medicine. David, it's over to you to frame today's conversation. Thank you.
Thank you, Georges. It's my honor and pleasure to join you for this webinar and to serve in this capacity as moderator. The topic at hand today is both timely and important. My hope is that we contribute to the national dialogue on COVID testing, help clarify some of the critical questions and issues at hand, and promote advances in this area. I am particularly interested in hearing some of the comments and questions from attendees, and we'll have a chance to do that after the presentations. Before we begin, though, I'd like to offer just some very brief framing comments. First, let me just ask a very simple question. What are the purposes behind testing? Next, please. The answer, in some ways, is quite simple. It's situational awareness about the virus in particular. But there are actually two different kinds of motivations for trying to build awareness or for undertaking testing. The first of these is shown here. That's the purpose of diagnosis. We ask questions related to diagnosis of multiple sorts. And in particular, we're interested in whether an individual has active infection, whether the infection is early or late in its course, and whether a person is in a pre-symptomatic phase. And in particular, in this particular infection, this is a critical question that we'd love to be able to answer with testing. We also want to know who is contagious, not just who is infected with the virus, and who will be contagious if not now. And then finally, in the realm of diagnosis, we're interested in predicting both the severity of the illness, the complications that might arise, the kinds of clinical needs and resources that we may need to devote, as well as the possibility of acquired immunity after the illness has transpired to some degree. There's also a second motivation that, that frames the question about why we test, and that's shown here. We're interested in the health of populations, not just the health of individuals. And this is a purpose that some call surveillance. Here, we're interested in, again, who is infected, who's immune, who's susceptible, but now at the level of a population. We're also interested in where are these individuals who are either infected, immune, or susceptible, and when are they present with one of these types of status. We also want to know what's the nature of the heterogeneity amongst people and across time. Why are some people infected or immune or susceptible at any given time? There's also a question about heterogeneity with respect to the virus, and that too is critical to understand both across space and across time. And then finally, within the realm of surveillance, we're interested in both designing and assessing interventions. And for this, the kinds of questions that I've posed here are important to be asked, but asked again repeatedly as interventions take place or are redesigned and reassessed. Finally, there's one last basic question that we want to ask, and that's really the question that our attendees and presenters here will want to address, and that is, how is it that we should undertake testing? And there are at least two issues here. One is that we can ask, what is it that we wish to measure? Or what is it that we seek to detect? And then the second is, how do we deploy these tests at the sites where they're needed? There are two kinds of measurements that we're interested in. One is the virus and one is the host. And within host response, there is the question of antibody formation, but lots of other responses as well that may have important predictive as well as diagnostic features. So these are some of the issues that I think we want to address here this afternoon. Now I think we want to continue on with the program. So today on this webinar, what we're going to do is examine the state of testing for COVID-19, the data that different tests provide, how it is that we use these data to care for individuals and for populations, as well as examine the equity issues that we all must consider, including the moral and health imperatives for equal access to testing. So let me now first introduce our three speakers. The first will be Dr. Jill Taylor, who is the director of the Wadsworth Center, which is the public health reference laboratory for the state of New York. In her current role, which she has held since 2012, Dr. Taylor oversees the day-to-day operations of the center and defines its future directions, both as a state public health laboratory and as an institution for basic and applied research. Jill has worked extensively at the federal level, serving as a member of the National Library of Medicine Board of Regents and also the CDC Board of Scientific Counselors for the Office of Infectious Diseases. Dr. Taylor will offer an overview of the diagnostic and serological tests currently available and what each tell us. Second, Dr. Ashish Jha is a physician, health policy researcher, and advocate for global healthcare reform. Dr. Jha serves as the director of the Harvard Global Health Institute, a professor of international health and health policy at the Harvard Chan School of Public Health, professor of medicine at Harvard Medical School, and a practicing internal medicine physician at the VA Boston healthcare system. Dr. Jha's major research interests lie in improving the quality and costs of healthcare with a specific focus on the impact of policy efforts. And finally, Dr. Georges Benjamin is known as one of the nation's most influential physician leaders because he speaks passionately and eloquently about the health issues having the most impact on our nation today. As executive director of the American Public Health Association since 2002, he leads the association's push to make America the healthiest nation in one generation. Dr. Benjamin is a member of the National Academy of Medicine and serves on the Emerging Infectious Disease Standing Committee. In April 2016, President Obama appointed Dr. Benjamin to the National Infrastructure Advisory Council, a council that advises the president on how best to assure the security of the nation's critical infrastructure. So, thank you all for being here. And let's turn first to Dr. Taylor to get us started. Dr. Taylor.
So good evening, and thank you so much for the invitation to speak at this really timely webinar. I'd like to thank both our hosts, the APHA and the National Academy of Medicine, for the invitation to essentially what I'm hoping to do is give you testing 101, and I'm going to do it in relationship to the testing that we've been doing in our own laboratory at the Wadsworth Center. So could I have the first slide, please? The second slide, please. So I clearly can't do this with, oh no, I'm sorry, can we go back one? I just need to assure you that I have no relationships, either fiscal or otherwise, with the companies that or products that I'll mention. So next slide, please. So I think the FDA has been in a very interesting position over the last few weeks, and this a website that I'm showing you shows the molecular assays, the diagnostic assays that are approved by the FDA under the EUA process. Perhaps it's important to give you a little bit of background about the EUA process. Once a public health emergency is declared, the FDA has a special mechanism that they use to provide their review and approval process under an expedited method, and that's called the EUA process, so that any tests that are available need to go through the EUA process. And in our hands, in our mind, the FDA has been extremely rapid and responsive in the review process, though clearly, as I'll talk about later, there have been some issues that you've seen in the press. When I put these slides, gave these slides to the APHA, there were 37 PCR-based assays that were available. Actually, there's 39 now, so things are moving very quickly. The majority of these are assays that should be used in a high complexity lab. They're real-time PCR assays that probe for particular genes of SARS-CoV-2. Mostly they'll use the N, the nucleocapsid protein gene, but I have seen ones that are for the E protein as well. There are actually 3 waved assays, which means that they can be used at the point of care. But the majority of them are laboratory assays that are used in a high complexity lab. There are, as you no doubt have heard, many supply chain issues for both reagents, for use in these tests, as well as for the supplies that you need before they get to the lab, including swabs and viral transport medium. And there's a great deal of ingenuity that I see in people finding ways to to get around these supply chain issues, including the use of 3D printed swabs, saline for BTM, and other approaches. Could I have the next slide, please? In our own assay, in our own lab, we're using 3 EUA approved assays. We were able to develop our own real-time PCR assay quickly and get it EUA approved. And this is a fairly typical multi-process extraction, liquid handlers for setting up the plate, and then real-time PCR, multi-stage assay. We're also using the Cepheid Expert Express assay, which is run on the Gene Expert, and the Pneumatics SARS-CoV-2 assay, which is a highly automated assay, sample to answer assay, which you can continually load. I think we found it's very important to have available to you multiple assays. Because of the supply chain issues, you can't depend on one assay, and I think that's been very problematic. I have a colleague in public health, Joanne Bartkus, who uses the cookie analogy. So I want to make chocolate chip cookies, and today I have all the ingredients, but tomorrow I've run out of flour. So I found a substitute for flour. I could use maybe rice flour, but now I have no eggs. And then tomorrow, I found an egg substitute, but I don't have chocolate chip cookies. And this has been a problem, chocolate chips. And so this has been a problem that has affected all of us for many weeks now. And so having multiple platforms available is really an absolute essential. Could I have the next slide, please? Which specimen to use is also a question that you have to think about. The nasopharyngeal swab is taken as the gold standard, but I think we need to be aware that we don't know what the what level of sample we're actually missing with nasopharyngeal. I've seen nasal swabs, and I've seen mid-nasal turbinate samples taken. And then, of course, the throat oropharyngeal swab, and also much discussion of saliva. Given the paucity of swabs that are available, I think it's important to look at saliva as a method, and we have done some work in our own lab. Could I have the next slide, please? We did a study in a high prevalence SARS-CoV-2 area and looked at 226 individuals and collected an NP swab, a nasal swab, and a saliva swab. And the NP swab was clearly the best sample, but the nasal swab and saliva were quite good also. So at the moment, we're looking at combining a nasal swab and saliva so that compared to the nasopharyngeal, we would be close to the sensitivity. So again, it's important to be flexible in terms of what specimen you collect, but also to be aware of potential for missing. Next slide, please. In terms of serology assays, which is the discussion of the moment, again, this is the FDA website. And when I, again, put these slides up, there were 70 serology assays available. Now there are 125. So you can see, again, the field is moving very, very quickly. This has been an area where I think there's been much confusion. The FDA has actually put up a list on their website, these 125 serology assays, many of which have been imported from China and Korea. And the what they're listed as is available for distribution. Many people have taken that to mean FDA, EUA approved, and it is not true. They are not FDA reviewed, nor are they approved. They are available for distribution. They're available for use in a high complexity lab. And I think that the FDA took that approach because they knew that a high complexity lab director would actually validate the assay before using it. But this is not happening. And there are quite strong disclaimers that need to be used with these assays. But there are many questions about sensitivity and specificity, especially cross-reactivity with the commonly circulating coronaviruses. So serology is an area that is very unclear at the moment. Could I have the next slide, please? In our own laboratory, we have used the New York State Clinical Laboratory Evaluation Program to have develop and approve our assays. We have a microsphere immunoassay using the Luminex technology, using venous blood, and we have submitted this to the FDA for approval. We have a microsphere immunoassay using blood spots as a sample source, and we're actually using this in a healthcare worker surveillance study at the moment. And we have the old gold standard, the plaque reduction neutralization assay, which I think is really the closest you can get to a functional assay, because the antibody actually binds to the virus and prevents it getting into a cell. So that's about as close as you can get in an in vitro assay to showing that you're inhibiting viral replication. I think it's incredibly important, and I'll say this again a little later, interpreting the results of these assays. Because somebody has either IgM or IgG means that they have developed an immune response. It does not say that they are immune. And I think the messaging and the communication that that is used for these assays is a very sensitive area and something that I don't think we've got right yet. Can I have the next slide, please? With any of these tests, you have to think about their positive and negative predictive value. So I put the math up for this. Positive predictive value is true positives over true positives and false positives. What that really means is if you get a positive result, what's the likelihood that it's correct? And on the negative side, if you get a negative result, what's the likelihood that it's correct? And really, positive predictive value and negative predictive value are dependent on the prevalence of the disease, as well as the particular characteristics of the sensitivity and specificity of the test that is being used. Could I have the next slide, please? So I think it's very important when you're considering bringing on a test to look at sensitivity. Sensitivity is incredibly important because of the impact of false positives. If you get false negatives, if you get a false negative so that you say somebody is not infected where they actually are infected and transmitting, then you're not able to do to prevent them transmitting, that person transmitting virus to others in their community. Specificity is incredibly important. As you know, there are 4 coronaviruses which circulate, causes of the common cold, and they commonly circulate. And many of the serology tests don't eliminate cross-reactivity. And so somebody can think they have immunity when in fact they do not. Reproducibility and ruggedness are very important. Also remember that the timing of specimen collection and the disease state, we have had samples submitted from people who had, they were in a car with someone for half an hour and so they're terribly concerned and they want to have a test straight away. And this doesn't give time for the virus, if they were infected, for the virus to replicate. And so timing of specimen collection is very important. And when a rapid test system is appropriate. This is an interesting question for me, because I have been a big proponent of rapid test systems and think that they are the future of diagnostics, but I worry about them and the ones that are coming out now, both for their sensitivity and the impact of false positives, their specificity, but also for the fact that they're very problematic for the public health system in terms of being able to track positives and negatives and know what the prevalence is in the community. So I am personally uncomfortable with the rapid test systems that are available, because I don't think that they give us the information that we need right now. So I think that technologically we're getting to the point where these are going to be very good. Could I have the next slide, please? So in terms of interpretation of serology assays, I think that they're good for seroprevalence studies, and certainly they give evidence of prior infection. But more study is needed. I don't think we can depend on them exclusively for returning to work without PPE, without protective equipment. And I don't think we can say yet that a person is immune just because they have IgG. I am much more comfortable using ELISAs or other quantitative serology assays, because you can deal with the issue of cross-reactivity and you can deal with quantitation to be able to answer these questions. And so I think that this is an area that we need a great deal of discussion. And I think we're next on the last slide. One more, yes. So there are a lot of seroprevalence studies going on that you'll see in the newspaper. You know that the NIH is studying, is doing a seroprevalence study to look at undetected cases of coronavirus infection, because it seems that there are a great deal of, a large number of individuals who do not get disease and yet are able to transmit the virus. There's a study in LA County, which is in the press at the moment. We're doing a small study in New York State at the moment, testing out whether our blood spot method will work. And these are going to tell us what the level of antibody is in the population. Ultimately, we need to understand the level of herd immunity that's going to be necessary to provide protection. And they'll help us plan to figure out how we start reopening the country and returning to work. So there are a number of these seroprevalence studies being used, being started at the moment. And I think that these are going to help us understand what the next steps are. And I think at that point, I can go back to Dr. Relman.
Thank you, Jill. Appreciate your comments. I'd now like to turn this over to Ashish.
Great. Thank you so much, everybody, and special thanks to both the APHA and the National Academies for co-hosting this entire series, which I think has been remarkable in its quality and its instructiveness. So I'm obviously very pleased to be here. So what I'm going to do is something different. I don't have slides, and I'm going to speak to you all about the sort of the policy and kind of frontline experience around the issue of testing. And as all of you surely know, testing has very much been in the news. And it really comes from the fact that for the first sort of 6 to 8 weeks of this pandemic, once the US became aware of it, we really did not build out much of a testing infrastructure. And Dr. Taylor actually did a very nice job of explaining some of the challenges, but it really does begin with the CDC initially foregoing the World Health Organization's testing protocol and working to develop its own, which they've been criticized for. I think it was not necessarily unreasonable. The CDC has a long history of developing its own tests and generally doing a pretty good job. But then there were a series of failures, both on the part of the CDC and the FDA, that really hobbled any ability of our country to build up a strong testing infrastructure. And so we wasted most of the second half of January and all of February essentially blind to the spread of the coronavirus across many communities in the US, certainly in Northwest US. Very good evidence that the disease was spreading in the community in New York and in other places. And now some emerging evidence that maybe even as early to mid-January, there was some circulation of the disease in Northern California and Santa Clara County. So moving forward, I think late February into early March, we start getting a lot of pressure to ramp up testing. And the testing really does begin to get moving. And what I'm going to do is talk a little bit about where we are on testing today, what the estimates are of the kinds of testing we need, think about how we might get there, and actually walk through a little bit of what are the ways people are making calculations about our need, and try to kind of finish up with where I think the policy world is and where it's going over the next 4 to 6 weeks, to the extent that one can even forecast that far ahead in the middle of this rapidly moving pandemic. So through the month of March, we ramped up to a sort of a height of about 150,000 tests a day, which is where we have plateaued for about 4 weeks. We have occasional days of ups and downs, but on average, if you look over the last 3.5, 4 weeks, we've been averaging about 150,000 tests a day. Our test positivity rate has hovered around 22%, which by most standards is way too high. And to give you a feel for comparisons, South Korea, which has been widely touted as the country that did the best job of using testing, tracing, isolation as its strategy, had a test percent positivity rate of around 3%, between 2.5% and 3%, suggesting that they cast a much wider net and caught many more individuals. Germany's positive rate has been around 6 to 7%. There are many countries that have achieved rates under 10%. And that's the WHO recommendation. They have recommended that if your test positivity is over 10%, you're probably not testing enough. And I think there's plenty of other evidence that the US is not testing enough when we look at its testing numbers of about 150,000 tests a day. So there are a whole series of things that hold us back from increasing testing numbers. And you heard some of them from Dr. Taylor, but they really range. And the way I think about this is they range from, there are literally places that don't have enough swabs. Actually, to use your chocolate chip cookie example, I love that. I've not heard that before. So there's some places that are missing flour, other places are missing eggs, some places are missing chocolate chips, and some places just don't have ovens. So that is the problem. And most states have some of those ingredients, but not others, right? So it's swabs, it's transport medium, it's test reagents, it's PPEs for providers who would actually implement the test. Many places don't have infrastructure, so they don't want people going to the emergency department, and they want to have people go maybe to a drive-through or some other place, but they haven't built enough of those to really accommodate the needs. And then over the last week to 10 days, a new kind of factor has emerged, which is very interesting, and it suggests a different kind of problem, which is there are states where there's actually plenty of capacity, but not enough testing. And when you dig into that and you think, well, what's going on there? What's happening is that states had put in highly restrictive policies about who's eligible for testing 5-6 weeks ago when tests were scarce. And so for instance, you were only allowed to do testing of hospitalized patients who were very ill. And as testing has expanded in those states, those guidelines have either not been updated or they have not been effectively communicated to frontline clinicians. And so there are many states where there's actually enough testing capacity and excess capacity, but people are not sending samples in. And so a whole host of reasons why testing has not ramped up any further. I want to talk a little bit about how much testing do we think we need. So there is no single number. And of course, when you begin the question with how much do we need, it starts getting at some of the issues that Dr. Relman got us going with, which is what's the purpose of all of this? What are you trying to accomplish with testing? And fundamentally, if the goal is very narrowly that I would like to be able to identify all or most people who are actively infected with this coronavirus. Then currently today we estimate, and others have estimated, that we need likely millions of tests a day, which is unrealistic, given that we're stuck at 150,000. The assumptions of people moving forward, and we've done a modeling exercise where we've tried to model out how many tests we need, but others have as well, is if we keep social distancing in place and look at the models that predict how many new cases there will be over the next 2, 3, 4 weeks, where we will end up as the curve is not just flattened, but comes down. One can imagine that in about 3 to 4 weeks, we'll be at a point where we might be having about 50 to 60,000 new cases a day. Just to be very clear, right now we're identifying 30,000 new cases, but no one believes that that's the actual number. Most estimates are that we have between 150 and 300,000 new cases a day happening in the United States. And there's a bunch of ways one can get there in terms of why those estimates. So if we decrease our new case incidence by about 60%, we may be down to about 50 or 60,000 new cases a day in a few weeks. The reason for that timeline is, of course, all of you know that governors are anxious to open up their states and start some amount of economic activity again. And so the exercise we have done is try to model, if you get to a point where, let's say nationally, we're at 50 to 60,000 new cases a day, about how many tests would you need in a day to have a shot at identifying a vast majority of those cases. And again, there's a lot of fuzzy language in my description, because again, if we want to be truly certain, we need astronomically high numbers. And when we have walked through that exercise, our estimates are that we need about 500,000 tests a day. Other people like Paul Romer, Danielle Allen, and others have argued that actually we likely need more like 10 to 20 million tests a day. And the way I have seen this is our approach is something one could achieve by essentially linearly scaling up what we are doing right now. If you want to get to 10 to 20 million tests a day, obviously you need a totally different strategy. And I'm not aware that we could do it through using RT-PCR, and we'd probably need a different technology with either antigen testing or other things, again, that others have more experience and are more expert on. But there are a variety of strategies for how you could get to tens of millions a day. The philosophical difference between these two approaches is that the approach that we have laid out really has a very, very substantial role for contact tracing and isolation. The idea behind it is you start with mildly symptomatic or more severely symptomatic, but any symptomatic people. You identify all of them that are positive, and then you do vigorous contact tracing. And through that, and then you test everybody who that person has been in contact with. And using that approach, you should be able to keep the virus reasonably well contained so that you can go about and have some amount of economic activity. In that model, we probably need at least 500,000, though I suspect probably more than 500,000 tests a day. But that's really the minimum floor. That number and all of the push towards testing, I think, has met initially, I think, with resistance from the White House. But ultimately, when I've spoken to people on the White House COVID task force, there is really no disagreement. Everybody agrees that we need a lot more testing. And despite, I think, the comments of the president and vice president, there is broad agreement, even in the administration, that we substantially need to scale up testing. But 150,000 tests a day are not nearly enough to bring caseloads down now. And it certainly is not going to be enough once we begin to open up our economy at all. Couple of last comments, and then I will stop and turn it over to Dr. Benjamin. The issue around serologic testing, which I think Dr. Taylor did a great job of explaining, are fundamental, and there is so much confusion in the marketplace, in civil society, among business leaders. They've really seen these two things as substitutes for each other, testing for the virus versus testing for immunity. Of course, we all understand that they are not, and that they mean very, very different things. And the idea that what we're looking for is immunologic testing as a way to open up the economy, in my mind, is a lot of fuzzy thinking. Because even if we assume that all of the central issues, again, we heard from Dr. Taylor around specificity, false positives, underlying prevalence. Even if you had a completely specific 100% specificity, which again there isn't, but imagine a very, very specific test. Even in places like Santa Clara, Los Angeles, other places, chances are that the underlying prevalence is sort of 2, 3, 4% at most. So it is hard to imagine how we open up our economy with 2, 3, 4% of people who are potentially immune. And of course, having antibodies is not equivalent to actually being immune, again, as Dr. Taylor laid out. So the enthusiasm for immunologic testing as the kind of panacea and as the alternative to testing for acute illness by actually testing for the virus or an antigen, I think is very, very difficult and very troubling. And a lot of the time I have spent over the last few weeks has been trying to explain to people that they are both important, they both give us critical information, but they are different from each other. And that we continue to need to focus on RT-PCR or whatever mechanism we use to identify acute illness, and long-term antibodies, IgG, et cetera, is really giving us some other piece of information that is not going to be particularly helpful for the issue of being able to control the viral infection in the short run. I will finish by just saying this is, I think, the #1 issue on the minds of most governors and members of Congress. I think there's been incredible bipartisan support for congressional leadership. You're seeing in the Senate bill, $25 billion put in for testing. The idea behind a national testing strategy is not that there will be a single new government agency that will run all the tests across the country. I don't think that's either necessary nor a good idea. But you do need some sort of a coordinating force, so that if one state has plenty of chocolate chips but not enough flour, and another state lacks chocolate chips but has plenty of plenty of eggs or whatever, that we can do exchanges, that we can really use the federal government and the power of the federal government to make sure we're making more swabs, that we're making more transport media, that we're making more PPEs that are important on this. It is hard for me to see that 50 states all competing for testing against each other is going to be the solution to get us to where we need to be. So we are, just to finish up, we are nearing that time where I think you're going to see states starting to open up and go through those phases of opening slowly and then more. It is very hard for me to see how, given what we know about this virus, how the viral spread isn't going to sort of take off again in a way that's really going to jeopardize our ability to take care of all the people who are likely to get sick, unless we have a very robust testing, tracing, isolation strategy. I didn't get all into the whole issue of tracing and contact tracing, which is a different one, which we can get into in the Q&A. But I think what's really important about this seminar has been sort of teaching all of us and reminding us that testing really is at the central, is sort of at the center of the entire strategy for how we're going to keep the virus at bay as we open up our economy. So let me stop with that, David, and turn it back to you.
Thank you, Ashish. That's really helpful. I'd now like to turn it over to George's. Dr. Benjamin. You're still muted. I'm sorry.
Thank you. You can hear me now. Thank you, everyone. So I want to just talk a little bit today about this whole issue of making sure that everyone has access to testing. So if you go to the next slide. So, you know, I've always talked about there being 4 reasons for health inequities overall. And for testing, I think they're all still relevant. So the idea is, of course, having access to the test itself. As you know, simply having an insurance card doesn't give you access to health care. There's all kinds of barriers to actually getting access to health. Same thing was true with testing. Obviously, differences in the quality of the tests used. Certainly, you heard from Dr. Taylor the challenges with the quality of tests and knowing what are the right tests to use and making sure that the plethora of tests that are out there, that someone is encouraging providers and health departments and others to use are of a high quality and appropriately validated to make sure you're getting what you think you're getting. A whole range of behavioral differences in how one's view healthcare. Same thing with testing, how we view testing. And then, of course, the big bucket, the social determinants that impact testing overall. Let's go to the next slide. So let's talk a little bit about the access issue. So again, having the availability of tests, assuming there's an abundance of tests in the community, where the test facility is makes a big difference. We hear lots of stories of people who find it difficult to get to wherever the test facility is. Because it's obviously you're looking for some place where you can get lots of people in, where there's throughput, where you can do physical distancing. But quite often these are not located anywhere near the minority communities. Drive-through versus walk-up. Everybody's excited about the drive-through testing, but if you're not in a car, whether or not there's a capacity for you to get that test by simply walking up to someplace else at the testing site. And of course, long lines. Particularly in inclement weather, is a big issue. So location and the mode of testing facility does play a role as a barrier to making sure everybody has equal access to testing. Messaging, I've always fascinated that we always told folks, if you think you're ill and you think you need a test, call your provider. Well, as you know, far too many people in our country, over 30 million, don't have health insurance coverage. Many of them may not have a provider. So in some cases, that provider becomes a gateway barrier to them actually getting tested, even if they're symptomatic. Of course, the other thing is making sure that provider understands the symptoms and signs. And although provider community is getting a lot better at this, that still remains a challenge for some of our patients. The cost of testing. Now, granted, the federal government is covering that cost now. But I was just looking, I saw the new saliva test is $118, $19, I think. And then you get, if you were to utilize it, you'll be able to then reimburse by your insurance company. So obviously, we have to work through that one, but obviously if you don't have insurance, you probably won't get the saliva test once it becomes more abundant. And then the cost of care. The fact that obviously you can get screened is one thing, but if you don't have coverage for the care, that can make a big difference. And let's say you go in, we found this with the Affordable Care Act and other insurance plans that many people will go in for some other reason. While they're there, their clinician finds that they have a condition that needs to be screened for, and the screening itself might be covered, but the actual cost of that visit is not covered under this. Now, obviously, the new stimulus bill that was passed does cover some things, but not all the things that we need to make sure people have access to care. Next slide. So as we talk about the quality of tests used, I mentioned earlier, trying to make sure that the test is of high quality. You notice that Dr. Taylor talked about the difference between being reviewed and approved. And many of the tests out there are certainly not approved. Some of them have been reviewed, and some of them, depending on where you get the test from, may not be either. We know that a significant number of tests that have been used have had issues around being high false positive or high false negative rates. In many cases, they're not confirmatory. So one really needs to understand the test that you're using. And we need to make sure that all clinicians that are using these tests understand what the rules are and the parameters of the test that they're using. And of course, you absolutely have to be sure you're using a reliable test. Next slide. And then the behavioral aspects. So communicating to the public, of course, can be very difficult. The complexity of these tests, there's sensitivity and specificity, when to take the test, who's eligible for the test. All of these things can serve when the messages aren't clear as to barriers to the public. Particularly in a public that doesn't necessarily get its information from the emails or from TV. They may not have a provider, again, that they're linked to that can send them the information. We haven't used a lot of radio, for example, to try to approach some of these individuals, particularly in vulnerable populations that may not get the information through the broad media that we have out there. There certainly always is fear of discovery. We've seen this through the years with people for cancer, for example. the patient who comes in with a lump in their breast or rectal bleeding, because, you know, they just really did not want to know that they had cancer. Well, the same thing with COVID-19. There are patients out there who probably ought to be screened, but just really don't want to know because they're afraid of the result. And we have to work hard to try to convince them that that's not something they should be worried about. It's better to know right now, particularly if they're symptomatic. Fear of stigma, you know, the fear that their family won't talk with them, that they can't go to work. That's a big one. I now am a little bit symptomatic. I'm not quite sure that I have COVID, but I really don't want to know because if I know, then I can't go to work. Those are some of the barriers that people have, particularly for those folks that are public facing and unlike many of us cannot work from home. And ultimately the lack of trust in the system. People who just fundamentally don't trust the system. They don't trust doctors, they don't trust the system, they don't trust the system results, and they've not built a relationship with the healthcare system that they trust for a variety of reasons. Next slide. And then, of course, those broad areas of the social determinants. The fact that we really haven't had adequate amounts of tests. The fact that we have been really symptom and exposure based in most cases for the testing, but not job or risk based for the testing. So now that will change as we get more tests out there, but just understand that we have created a barrier for many of the people who are out in the community, out working, who then get symptoms. Theoretically, they should be captured under a symptom strategy, but for many reasons they're not. And again, some of that is because they don't want to lose work days. Testing times not being aligned with their frontline job off hours. So if you don't work, you don't get paid. You don't get paid, you don't eat. So the likelihood of you going to get your test at a time when you have to be at work can be a challenge for many workers. Not having paid sick leave is a part of that problem. Now, again, not having to use your source of health care, not really understanding where you go. And obviously the emergency room is not an option. We're not sending patients to the emergency room for tests. We are sending patients to the emergency room for symptoms, but only when they're really sick. And as you know, far too often patients wait until they're really sick, even to go to the emergency department. And of course, the emergency departments right now are very crowded. And of course, high cost. I'm reminding you that if you go in with a sore throat, you may have COVID, but even under EMTALA, they have to do a evaluation that may not necessarily include a screening exam. And then, of course, you'll get hit with the high cost of that emergency department visit because it would be generally viewed as a non-urgent visit. And then, obviously, we always have to think about bias in testing, racial and ethnic biases. I put possible because we know it exists in other parts of healthcare. We've heard lots of anecdotal stories of this, but we just have to, you know, someone really needs to do the science and make sure we understand that. And we have to call it out when we see it because it certainly does occur. As you know, a lot of it may be unconscious bias, but it's something that we just can't ignore as part of the social determinants of health. Next slide. So let's talk about risk. Next slide. So I wanted to just talk a little bit about the Los Angeles antibody study because I think it tells us some stuff. This study just was released yesterday. It was a drive-through antibody study done April 10th and 11th at 6 sites. They had a universe of a little over 800 participants using a proprietary database that was allegedly representative of the county's population. They used a rapid antibody test that they felt was 95% accurate. And of course, it was then verified again by a Stanford University lab. You see that I had the lead investigator. And again, most of the stuff I'm using is in the public domain. I don't have any secret information from them. But this is an important study that was done because I think it just came out and it gives us a sense of where people are going, particularly with these serology studies. Next slide. So interestingly enough, there was a range, as you see, about 2.8% to 5.6%, but on average, 4% of the county's adult population was antibody positive. And that means that if you extrapolate that to the whole county, that somewhere between 200 and some and 442,000 adults at least are antibody positive, which would imply they've had the infection. But I just remind you that, as Dr. Taylor said, that does not imply immunity, but that does imply at some point they were exposed to the virus, and they certainly mounted an immune response. And then this estimate is much higher than the almost 8,000 confirmed cases that they had reported in the county in early April. And their deaths are over 600. So this would imply, also, if you just do the math, that they probably have more cases out there than they could have predicted before. Next slide. So if you think about the demographics in Los Angeles, this study found that about 6% of the men were positive, 2% were women, so more men were likely to test positive. Those findings are real unclear. They have not felt they could explain those yet. But 7% of the African Americans were positive, 6% of the whites and 2.5% of the Latinos in their study. Next slide. And I think it's important to understand that the percent of individuals who are African American in Los Angeles County are pretty much representative of the nation's, around 12% or so. So compared to whites, that's really disproportionate to the number of whites in the county or in the nation as well, which is around 60%. And I think it's important that we understand these are early results. And these are my interpretations and not necessarily theirs, but these are early results. And like any study, it needs to be repeated by somebody else using the same serology tests in a community very much like the one they tested. So we're looking at big city, Chicago, New York, someplace like that. But it does confirm about the penetration of the virus in community, clearly well below herd immunity. Whether you're a 50% herd immunity person or a 70% herd immunity person, is certainly well below what we would consider herd immunity. And that 4% is relatively consistent with the WHO estimates of 3 to 4% globally that they've articulated for the seroprevalence of people in other studies that they've looked at. It also says that males, particularly Black men, seem to have a risk of infection that is disproportionate. Again, early study, we need to know why. We do know that there's a disproportionate number of African Americans who get sicker and a higher mortality rate, particularly if you have chronic diseases. But what this all tells us, again, we need much more data, much more studies to find out. And I know that they're doing other kinds of seroprevalence studies. So hopefully this will become more clear to us. But I wanted to say this because I think this gives us an example of what we're going to see in the next several weeks as more people do these kinds of studies. And for all practical purposes, this begins to give us a sense, begins is the key word, of what the denominator is and whether or not the mortality rate that we're looking at that we've all feared is different or not. Again, as you know, there are many species of coronavirus, and that's one of the challenges that we have, making sure that clearly the serology picks up exactly the virus that causes COVID-19. Next slide. So I don't like to put out a problem without talking about some kind of solutions. So quickly, next slide. So obviously we need to plan our testing access with the underserved in mind. So think about location, thinking about the cost issues. Again, recognizing that the tests may be free, but there may be associated costs that we have to figure out how we mitigate if we want to get access to testing for everyone. Ensure that the test is actually one that's, I prefer an approved test, but obviously, as Dr. Taylor pointed out, many of the high quality test sites, particularly the academic sites, many of the public health sites may be reviewed They do a lot of validation of their tests, and as long as the lab understands the reliability and parameter of the test they're using, that's important. And addressing testing education and communications in a culturally competent manner so that people actually understand what the tests are. Explaining to people what false positives are, explaining what false negatives are, so that they understand, yeah, doc, I'm getting the test today, but what does this really mean for me? As Dr. Taylor pointed out, getting the test right after you've been exposed, maybe exposed to someone at work or a car, isn't going to give you the result that you want. You have to wait for some period of time, either become symptomatic, then you know that's usually somewhere around 3 to 5 days if you have a meaningful exposure to that individual. And of course, using trusted messengers is very important so that all communities understand what's going on, and meeting the social determinants head on to make testing easier, particularly dealing with unconscious bias or conscious bias, because I think that's important for us to not ignore and continue to address as we go forward. I think that's my last slide, but next slide. Yep, I want to thank you very, very much. Okay. I'm going to turn it back over to David.
Thank you, Georges. It was a very helpful presentation as well. We're now going to begin the audience question and answer portion of this program. We have just 25 minutes for what looks to be about 150,000 questions, which I think speaks to the importance and relevance of this topic, needless to say. We've made some effort here to try to bin commonly asked questions into sort of general framework so that we can address as many of these questions as possible. So let me just start now with a couple of questions for Jill Taylor. And these are questions that really have to do with how we can understand better the current performance characteristics of both viral detection and serologic tests, and understand where is it we need to be with these performance characteristics. What are the sensitivities and specificities that we might need given a likely pretest probability, let's say, of a population with 2 or 3% seropositivity, and whatever degrees of viral circulation we think there is. What are the test performance characteristics that we're looking for that someone who's taking a test might want to hear before being willing to trust the result that they get?
So, as a scientist, I can read the performance characteristics and understand that, you know, I want to be able to detect 10 genome copies, for instance, but that's not readily translatable to a non-science audience. You want to know that it's high 90s sensitive, 90%, 95, above 95% sensitive, and well above 95% specific. I think with serology tests, which most people understand more, the issue is one of cross-reactivity, and I often think that being able to use a quantitative test rather than a qualitative test gives you more comfort in understanding the results. But ultimately, there is no perfect test. And that's why I agree with Dr. Benjamin, either approved or go to a high quality lab, and then you depend on the expertise of the lab director to validate and verify the quality of the test.
Thanks. Let me also just ask a question about this cross-reactivity issue.
Mm-hmm.
A number of people are interested in what we know and don't know about the likelihood that a positive could in fact be detection of antibody against a seasonal coronavirus. How many of these vendors have actually not only done the proper controls with those sera, but tell us about them in a credible way.
Very few, to be perfectly frank, and that is a real issue, especially with the fact that we've all had colds, every one of us, and you never go to the doctor with a cold. You rarely get bled, so there are very few controlled sera available that you know is from somebody who actually just had a 229E, and that's one of the coronavirus infection. So there are no controlled sera available, very rare. And so very few of the manufacturers have done, especially of the rapid tests, have done the sort of specificity testing that is required to say, yes, I'm positive to SARS-CoV-2, but not to 229E. That's why I like the quantitative ELISA tests, because you can set you can set the baseline well above detection of antibody to those viruses, so that you know you've got positivity to the SARS-CoV-2. Unfortunately, they have to be done in a lab, those sort of tests. You can't do it in a rapid test. But it's something that the public has to be really aware of, because there definitely is cross-reactivity.
Thank you. You and the other two speakers all pointed out the important distinction between presence of antibody and presence of protective immunity. A number of people have asked, what will be the path to an understanding of what antibody means? How will we be able to move quickly to either a test or an understanding of current tests, such that we can make some prediction about protection?
So I think that there are studies that are being done in primates looking at the potential for reinfection, but primates are not humans. And unfortunately, we're going to have to wait to look at the potential and frequency of reinfection, knowing the immune status of the person who was reinfected, before we have that information. And that's unfortunate, but that's the reality.
Thank you.
And obviously, you're going to have a population of people who have been infected, who we know have been infected, and doing in many ways, it's a natural history study and watching them over time, particularly if those people are going back into high exposure environments. And unfortunately, it sounds like our healthcare workers.
Yeah.
So we have to protect them, but that's going to help tell us what's going on.
Right. And maybe just to underscore, natural history experiments, essentially, of that sort, which are going to be so important, necessitate periodic but repeated testing of the same individuals, which is how we get to these very large numbers of tests needed. I think a lot of people, look at the population of their county or the state or the nation and ask, well, once we get to that number, are we done? And I think what you're just pointing out is exactly the kind of experiment that's critical, that in fact requires sequential, frequent testing, retesting of the same people.
Yes.
There are a number of questions, not surprisingly, about how do we get to the place that we need to be in terms of numbers of tests, as well as the key people that we need to be testing. And so this is really a question about deployment. And I think probably all three of you might have some very useful things to say, perhaps starting with Ashish. You've mentioned some numbers that we might need to try to attain. And the question is, how do we get there? And in particular, what do you think is the most effective blend of national role and responsibility versus state versus local? How do you properly empower and resource each of those authorities to work together towards the ideal solution?
So thank you, and it's a really fabulous question. And I want to make kind of 2 points about testing numbers. There are right now, I think broadly in the kind of ether, two sets of numbers in terms of what we want to target. There's a 500,000 a day number that we have been arguing for, which is really a linear scaling. And then I alluded to Paul Romer, Danielle Allen, others who've been arguing for 20, 30 million. There's a new Rockefeller Foundation report that I think says 10 million a day. You don't get to 10, 20, 30 million by linearly scaling. So you just need a total leap of technology. And I think I mentioned that earlier. And that's going to require a bunch of investments on the part of I think the federal government to create incentives for new technologies, and then obviously deploying a totally different testing framework. So I'm going to leave that aside for a second and talk about in the next 4, 6, 8 weeks, if we're going to be able to get up to 500,000, how might we do that? And then that mix of federal and state. So I actually think it is achievable to get to 500,000 a day. It does require a very substantive role for the federal government. And the role of the federal government has to be certainly to provide financial support to states. I think a lot of states are starting to financially get into struggles with obtaining all the equipment. The coordination is really about making sure we have enough supplies, deploying the DPA to the extent that the Defense Procurement Production Act, to the extent that that is needed, and then really coordinating supplies across the country. I think that those are very, very appropriate roles for the federal government. So the way I have seen this ideally play out is that one of the things that states have to do, some of the most successful states all have testing czars. Again, I don't love the idea of putting a czar on everything, but and you can call it something else, a testing coordinator. But if you look at states like Utah and New Mexico, which have actually done a very good job on this, they have a testing czar whose day job every day they wake up, go to bed, thinking about how do you get testing up and running. So I think states should really take ownership, do that, and then the federal government should be getting involved with technical support, with financial support, and with logistics and supply chains and all the things that states cannot do. That's, in my mind, the kind of ideal federal-state partnership, especially under the current circumstances where I think a large role for the federal government is unrealistic. But that kind of partnership could be something that could work out.
Thank you. Georges, can I ask you the same question, but with the focus on the large populations for whom contact with the testing infrastructure is simply not, a current common occurrence. Do you see a path towards, again, deployment and dissemination out to the critical people that need to be tested? These are both the medically vulnerable, but the economically vulnerable as well.
Yeah, absolutely. And so we're going to have to take what we learned during the HIV/AIDS epidemic and put it on steroids. And that means we're going to have to use a range of community health workers, outreach workers. We're going to have to build on the disease intervention specialists that each state or local health department have. And we're going to have to build call centers so that we can manage the input, so that we can leverage the knowledge we have around testing with who do we have to go out and test. And that's particularly important around the contact tracing. I know there is a coalition of many of the public health groups that are working with CDC now to try to put that together. But it's going to take a real Herculean effort to make that happen. You saw that Massachusetts has talked a great deal about doing this as an example. But it creates, the systems exist for us to do that. We understand how to do it. We're going to have to do a lot of virtual training, for example. And I also think that spending some time over the next few weeks, in fact, days to weeks, getting the communications right and figuring out how do we communicate and who do we communicate. As I mentioned, it's nice to have the ad council's ads on TV that talk about physical distancing. But I think we're also going to have radio. We're going to have to get the media involved. We're going to have to get some of our sports heroes involved in order to reach the population so that people understand where they go, what the value is of that testing. And then we're going to need to wrap all of this around with an effort to get rid of a lot of the misinformation and disinformation. Because I can see it right now. People saying that if you get tested, you're going to get some disease that you don't like. We see that with vaccines when people want to, undermine the vaccine effort. And in Washington, D.C., we spent a fair amount of time talking to beauticians and barbers and faith leaders and getting them to be part of the trusted messengers that I talked about.
Thank you. I want to ask all three of you a similar question, which is how do we think out of the box right now? All of you have alluded to challenges that are in some ways challenges that we as a nation or as local communities have not yet been able to accomplish. And yet we clearly see that we have some challenges that have to be addressed now. So in each of these three ways, I'd like the three of you to think about how do we, what to you seems to be the most promising out of the box set of opportunities. So maybe starting with Jill, if you could just talk about some of the technologies that you think are most promising that would allow for, rapidity, flexibility, forward deployment, ease of interpretation, et cetera. Are there any that you'd like to highlight just as generic technologies?
So I'm not going to answer your question. I'm sorry. I'm going to talk about a gap that I think I see, and that is electronic communication. As I mentioned, I'm a big fan of the point of care tests because ultimately I think getting them into the home, getting them into the pharmacy is absolutely the way to go. And with the CRISPR-Cas type approaches, high sensitivity, we're pretty much there on the technical side of things, I think. But the issue is that, if you do a test at home, the public health system has lost that data. And so to me, it's the connectivity of the system and every urgent care center, every physician office lab, every LabCorp Quest, every big hospital, it all has to be communicated. And so but the Microsofts of the world, the Amazons of the world can connect everything if you're buying something. So why can't we connect everything if you're having a test? So, one of the good things that might come out of this horrible time might be that we're accelerating the development of interesting solutions. And that would be a good thing. So I'm not really answering your question, but I'm hoping that somebody comes up with a wonderful solution for that, because that's what we need.
Well, I think actually you did answer it very well. And in fact, maybe one up the question. Ashish, let me just ask you, from the point of view of data collection and data sharing, do you see some interesting opportunities that you would like to see promoted? Some of the people sending in questions have asked about crowdsourcing as a kind of a generic concept.
Yeah, so let me say a couple of things, and then I'm going to talk about one of the things that worries me as well about this idea around data sharing and data fragmentation. So I think Jill is right, Dr. Taylor is right, that that this virus and the way it is playing out may in fact do enough kind of jumbling up of our healthcare system and all the sort of traditional boundaries we've had around data sharing that it may sort of push those enough. So for instance, I think over the summer, as we gear up for the fall and get ready for what will almost surely be more waves of the virus, assuming that we get through the summer reasonably okay, I think there's going to be a lot of pressure to create a lot more connectivity across health systems, to be pulling out data, to be sharing data. And now the business model for that is very, very different than what it was 5 years ago or 2 years ago. So I see that as the upside here, that it may make the sort of traditional data blocking, we're not going to share with these guys because they're our competitors, those feel really anachronistic in the context of a pandemic. And so I hope that maybe some of this pushes us and our healthcare system to be much more integrated from an information point of view. The part that worries me, the fragmentation, is, and this is really gets at the heart of a lot of what George's was saying as well, is that what you're seeing now is entire industry come up that will go to companies, and I actually have had a bunch of them approach me. I'm not part of any of them. Basically going to businesses and saying, we'll sell you the ability to bring all your workers back because we will test them on a regular basis. We will provide the PCR test. We'll provide the immunologic test. We will make sure that all your workers are safe. That is a very interesting business model. Those companies are going to get access to tests that maybe states will not have access to. And they will deploy them not based on risk or who's clinically most likely to suffer if they get the disease, but who is the most economically, who can kind of pay for it. And so when we saw NBA players getting access to the test where really sick people in hospitals couldn't, now we're going to see healthcare executives and lots of people who are in higher STS status, socioeconomic status, being able to access tests and get tested regularly. And I worry that COVID test negative or immunologically positive becomes essentially a status symbol and becomes a way to be able to work in a way that really is going to be harmful. And also all those tests happening within companies will create a fragmentation because public health will never have access to all that data. So there's a set of policy challenges that we need to start thinking about now because the marketplace is moving extremely fast in this area.
And you know, that brings us to the issue of these immunity certificate idea, right? Getting a card, right? Yeah, just like your credit card has its privileges. Having a little card that says, boy, I am, seropositive. In the past, that would not have been something anyone would have wanted to say to one another. But now it sounds like that's okay. I'm seropositive and I got a green card, blue card, purple card, which proves that I have that. And the problem with that is, of course, is that it becomes extraordinarily discriminatory. And then, you can make a lot of money on the black market selling that fancy card to folks. And so you basically build a black market. And so immunity in terms of the validation becomes not very helpful. And then we run the same risk as we saw with people being concerned about HIV. Now not wanting you to know whether or not you are, you're not seropositive, for example, because that could mean that you don't work. Right now we're leaning on that now by telling people we're going to take your temperature, right? And that has some clinical value, but I worry about that, and I do worry about it being misused. Now, having said that, I think we're absolutely on a new curve of technology. We can get an EKG. We can get money out of an ATM machine anywhere on the planet, 24 hours a day, 7 days a week, and yet we can't exchange some of the basic information around seropositivity across all our healthcare system. And so we're going to have to, we got to protect people's privacy, that's for sure. But we've got to find a way to make these boxes talk to one another. The technology is there. Amazon does it. Your local grocery store does it. They know exactly what's coming off the shelf. And now that the federal government's beginning to put a little money in the HIT for public health, we need to once and for all build a robust surveillance system that's national in nature, that gives us real-time information. And I got to tell you, when I was the health officer in Washington, D.C. many years ago, and I was looking at infant mortality 2 years in the rear, and the fact that even the opioid epidemic now, we were still looking at data many, many months in the rear, sometimes a year in the rear. We can fix this. The technology exists.
Great. Those are really helpful, insightful comments. I think we're close to the end of our time. There are so many more questions here. I'm hoping that there is an opportunity to have them addressed, to engage all three of you further in this conversation, because there's so much more that could be said. Let me just offer a few concluding remarks. First of all, I think it's really important when we think about testing and the current conversation about testing that we step back for a moment at first and ask, what is the question? What is the question that we seek an answer to, for which we think testing is the right approach? Because until you've defined the question, you don't really know how it is that you should be deploying a technology or framing a study or interpreting the data. Second, I think we've heard from the three of you and from actually the attendees as well, that there are still some important tactical or technical needs that are important and probably should be high priority right now. One is that we don't yet have one testing kit that clearly outperforms others. And so for now, there may well be value in deploying multiple platforms that seek to do the same thing. In this case, you could say that redundancy can be useful. I think there is value in targeting virus as well as host response. And again, by host response, we mean serology, but not just serology and antibody, perhaps other host markers that tell us who is incubating virus and not yet sick, who is sick and destined to need a ventilator, who is resolving their infection and is likely to become immune. That kind of capability would be really impactful, and I think is possible technically through a whole variety of interesting science and technologies that we haven't really had a chance to discuss all that much this afternoon. Third, from a tactical point of view, all of this has to be scalable, and to varying degrees, depending on who you listen to right now, perhaps massively scaled in some cases. And so we're gonna have to think, I think, in ways that are non-traditional, technically non-traditional in terms of infrastructure and organization to be able to make that happen. And really deployment is the critical need right now, because probably a number of good enough tests right now that we'd love to see much more further deployed and then penetrated into the various aspects of our societies. And we're just weren't prepared to do that, and we still haven't quite figured out how to do that as well. And then finally, there are the issues of governance on testing that we touched on this afternoon. We could talk further about what the right kinds of partnerships might be between federal and local, between private and public, and between all the other kinds of sectors that have very useful things to contribute. But right now, I think we certainly need a more effective organizational scheme for taking advantage of these different kinds of skills and expertise and capabilities so that we can leverage and synergize rather than simply add or, at worst, compete. And then finally, I think we certainly don't want to forget the questions of equitability, of data sharing, of these more meta features that are so important to taking advantage of whatever information and knowledge we've gained from testing so that we can make good public health decisions. So let me just say that concludes today's webinar. The next webinar will take place next Wednesday, that's April 29th at 5 p.m. Eastern Time. It will focus on COVID-19 and health equity, exploring disparities and long-term health impacts. Everybody who registered for today's webinar will receive an invitation to the next webinar. And just to remind you, this webinar has been recorded. The recording and a transcript and the slide presentations will all be available on the COVID-19conversations.org webpage. So look for those items there. I, again, from the bottom of my heart and from the APHA and National Academies of Medicine, want to thank the three panelists for really wonderful presentations and comments. Want to thank the two sponsoring organizations for their efforts to make these webinar series possible, and this one. And finally, I want to thank all of the listeners who joined us today. Please stay safe and healthy, and take care.